Are you a manual therapist ready to expand your clinical reach and deepen your effectiveness? Upledger Craniosacral Therapy addresses deep restrictions, supports neurological and fascial systems, and enhances whole body function by working with the body's natural healing processes. For over 40 years, Upledger Institute International has led the field of craniosacral therapy, offering an approach that integrates seamlessly into any manual therapy practice and supports common to complex and chronic conditions. Find a class near you at upledger.com/courses or call 800-233-5880 extension 2 and begin your craniosacral therapy training for as little as $100 a month. Stop straining your hands and start getting your clients underfoot. At the Center for Barefoot Massage, we teach you to use gravity and physics to deliver effortless, deep myofascial work. Through our fasci-ashi approach of myofascial ashiatsu, barefoot mat work, and stretch therapy, you'll learn evidence-based techniques to resolve persistent pain. Worried about your size difference in relation to clients? Our innovative Ashi strap supports therapists of all builds to vary pressure with precision. The future of massage is afoot. Discover our upcoming CE classes at centerforbarefootmassage.com.
Hey, I have a client who, listeners, we have a special treat for this episode. My friend and colleague, Dr. Portia Resnick, has a new book called The Anatomy and Physiology of Sports Massage. I had the honor of writing a foreword for this book, and I have worked with Dr. Resnick over many years through the Massage Therapy Foundation and in some other contexts as well. And I've invited her to come and talk to us today about the critical thinking process when we have a client with a specific kind of unusual injury, like you would see if you were working in advanced sports massage settings, and what the decision-making process might look like to help get this athlete back up on the field as safely and effectively as possible. And that really has been, I believe, the purpose of this book is to help guide people through this decision-making process. So, Dr. Portia Resnick, please introduce yourself. Tell us what your current titles are, and then let's talk about your book.
Well, great. So, yes, I am currently an associate professor at California State University, Long Beach, so Cal State Long Beach. I am board certified both as a massage therapist and as an athletic trainer, and I kind of took a long clinical career and turned that into academia with getting my PhD to be able to work at this level. But I love the clinical side of things, and I am much more of a clinician. I always say I'm a field rat, not a lab rat, when it comes to research. Because I love the clinical aspect of things, and I was approached 2 years ago about a sports massage book, but it's something that had kind of been percolating back in the back of my brain for a little while of what I would want to see in a sports massage book. And so the book is kind of divided up with kind of the background of like, why do we do massage and what are techniques? And then looking at the anatomy and thinking about how do we kind of combine the two? Because I feel like many times, especially when you look at athletic trainers, physical therapists, occupational therapists, they do manual therapy, but they don't understand it in the same way we do as massage therapists. But as massage therapists, we don't always understand the sports and the application of the massage in this realm. And you don't have to know about sports to be good in working with athletes, but you have to know your skills, you've got to know your anatomy, and you have to know what questions to ask. And so I feel like this book was really able to kind of bridge that gap a little bit for me.
In my experience, the most successful textbooks scratch the itch that we have, right? So we write the book that we wish we had, to help us get to the place we have wanted to be. So I think that's absolutely wonderful. Can you give us an example of this clinical decision-making process? And people who have worked with me in the past will know that I am all about the critical thinking, and I'm all about the identifying key variables to help us get to good decisions. One of the reasons I was excited to participate in the forward of your book and in providing a little bit of a platform for you here is because we're on the same page there. So I'd love for you to talk us through maybe a real life scenario where you or someone that you work with has dealt with athletic injuries by using this kind of thinking process.
I have a client who is a football player at the college level. He is going to be, so it's the summer, and he's going to be a fifth-year senior. So he's going into his last year of eligibility. And during summer strength and conditioning, tears his pectoralis major. Specifically, it was a tear of the sternal head because it's funny, I asked the athletic trainer, I'm like, which head was it? Because I'm the anatomy geek. And he goes, I don't know. So I ended up, luckily, I knew the surgeon. And so I had a good conversation with the surgeon afterwards. And I know this is not typical. Not everybody has access to the physician. But this is why it makes such a great case study, because I was able to ask the physician, I'm like, which head was it? It's the sternal head. I'm like, okay, that just gives me some context. Did it matter? No, but the anatomy nerd in me wanted the answer to the question. Summer strength and conditioning, torn, and it was his right side, so his dominant arm. Position he played, which is important, he was a tight end. So he was playing on the offense, and he has both blocking responsibilities, so kind of moving from here to here with the blocking responsibilities, but he also has pass catching responsibilities. So at some point, he's got to get his arm up above his head as well. And so these are things to kind of think about. Because if he was just blocking, I'm like, okay, you don't have to get your arm up. For life, you have to do this. But for the season, you only have to get from here to here. Right. But at the same time, you don't have to get here. We can kind of make it work with you with your range of motion. And immediately, post-injury, he was put in a sling. So now we know he's internally rotated at his shoulder. He's in the sling. We've got to get the imaging done. We have to get everything kind of set up to get surgery. We know he's headed in that realm, but we're not doing surgery. It's not an immediate surgery. So he had a few weeks, and I can't remember if it was 2 or 3 weeks in the sling before he had surgery. And then he probably had another good 4 to 6 weeks in the sling post-surgery. So we're looking at a long window of time where he's in internal rotation of his shoulder. So that's something to think about. Some other things to think about, again, good answers that I got from the surgeon. They're not stitching the two ends back together so that they're meeting. So the muscle's going to be shorter on his right side compared to his left side. So if we think about that from a symmetry position, he's now got a little bit of shortening. He's going to have
anatomical shortening, not just from functional shortening.
Not functional.
And was this with stitches or staples or glue or?
He said, we use a tape and it's strong enough that you could hang yourself.
That's an image.
I was in Oklahoma at the time. It was very appropriate from this particular surgeon. But he said, I use a tape and it's strong enough that you can hang yourself. And I was like, no more questions needing to be asked. So yeah, to me, that's always a curiosity, right? Are we worried about stitches, internal stitches that might be breaking? Are there staples? Are there tacks? Is there hardware in there? And he referred to it as a surgical tape. But we know we're getting the shortening, so we know the scapula is also going to be malpositioned a little bit as we're keeping that positioning within the humerus. And so everything's going to be thrown off a little bit. So now he gets when you look in the book, I have functional considerations and structural considerations. So now a muscle strain is a functional something, right? But this was well beyond that in the fact that, as you said, we're changing his structure literally within the body. So that kind of adjustment is something that we always have to keep in mind, that he's never going to have that symmetry that he had beforehand within this situation. So again, kind of thinking about some of those things. Considering, I was part of a care team, so we had the strength and conditioning aspect. So he was still doing I would walk in the weight room, even pre-surgery, he's got his arm in a sling and he's doing one arm work with his strength coaches, and he's still working with his legs. So he's keeping his strength and conditioning. He's running or riding the bike as tolerated within that. He post-surgery has a care team of athletic trainers that are taking care of his rehabilitation portion of that. They're doing those therapeutic modalities. My role was just within massage, and it was just hey, what can you do to help him within this? So we know we've got this positioning. We know he had this surgery. We know he's going to have range of motion restrictions. So those are other things that I needed to consider. When is he allowed out of the sling? When are we allowed to work on his range of motion? So prior to working on and him really having any range of motion within his shoulder, really what I cared about was his upper back and neck, because the poor guy has been in a sling for a long period of time. So I'm thinking about all of the other structures that are holding on, and why I love the shoulder. I hated the shoulder as a student, by the way. I love the shoulder as a clinician because it's so much muscular attachment, and I can figure out how to work and relieve pain, even if I can't work in the area where his injury is. So we could work trapezius, and we could work on rhomboid major and minor, and we could work gently on the posterior rotator cuff muscles that are holding him in place without, again, introducing any range of motion. I could work on latissimus dorsi, which works very well with pec major, and I know is going to be taking up some of the slack, again, without really being concerned about his range of motion, but giving him some relief in those areas. And so that was kind of my initial plan of care. What can I do to kind of help him feel better, but not do anything to kind of mess up with what's going on?
Well, let me ask you, Portia, at what point in this injury process were you brought into this? Was it pre-surgical, post? And if post, how long after?
Ironically, I was doing a different research project with him. So I saw him throughout, but I did not really start the massage work until post. And I want to say we were at least 4 weeks post-op.
Okay.
Before I was brought in to say, yeah, let's start to add some manual therapy in it. And again, I was very clear with, okay, what are restrictions about range of motion?
Right.
That's the question. And I want to say we were closer to 6 weeks before I could start to add some range of motion.
So his PT or an OT team, they were not doing manual therapy with him. It was really it was mostly exercise machine kinds of things.
Exercise and therapeutic modalities, electrical stim, but no hands-on really within there, because it was, even though they kind of knew what to do, they had me there. So why not, ask me to kind of consult on that. And like I said, I'd been around him for a while because he was one of my research participants. So I knew when he was
in an entirely different project.
All right. So he knew me, he trusted me, and it was really a good working relationship to be brought in for that. So probably between that 4 to 6 week mark, when he was able to start easing out of the sling, was when we started with some of the manual therapy. And I'm always really particular as well, where there's certain muscles, and subscapularis is one of them. I refer to it as not being a first date muscle.
I know exactly what you mean.
And it's not fun. And you have to build that trust with somebody. And so I built the trust by relieving all of these symptoms that he didn't realize he was having, and working on these areas. And then when it got to the other area, he was like, really? Because I worked pec minor, pectoralis minor, which is also a deep muscle. And I'm doing these, but I've got to build that trust with him. So we started with the prone work, eventually got him supine, and really started loosening up, and really just some gentle glides and just some gentle passive movement until we were able to get full range of motion. And I'll skip ahead a little bit, but I remember working pec major, and he had some really good range of motion. So we were doing a pin and stretch. So I'm holding and he pulls, and I felt a boom, 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 boom. And I went, ooh. And then he went, oh my God, that feels so much better. And I went, okay, that was scar tissue.
Oh my gosh.
But for me, it took a second, but I was like, and he was like, oh, that feels so much better. And I was like, oh, thank God. Because I had a little moment of panic in there.
Ah, no kidding.
It was clearly, yeah. And it wasn't in the region where the tear was. It was just him loosening everything up. But I was so in tune to what he was doing. And I went, And of course, you don't want that to show on your face,
Right.
all when you're working with someone, and it did not show on my face. But I was kind of like, and then he went, oh, that's exactly what I needed. And I was like, okay, we're good. Like it wasn't a pulling or giving sensation, but it was very, very gentle.
Yeah, you weren't like ripping through well-established things. He was just loosening the fascia, and it sounds like it was mostly led by him.
It was led by him. It was completely led by him. So it wasn't a passive thing. So he was completely in control of everything, and he really felt like he could now get his arm up above his head, which was nice. That was 3 or 4 sessions in. That was not the first time that I worked on him, so it took a little bit of time to kind of get there. And again, he was a few weeks out, and he was into that being able to go through full range of motion, which is why I had him in that position. And then I remember the first time we did subscapularis, and he was like, what are you doing to me? What are we doing? And then it got to the point where he was like, oh, now I feel the difference. And again, he's in that internal rotated position. His scapula is now malpositioned. Like that muscle needed to be worked. And again, he didn't like it at first, but once he felt the difference, he was like, okay, yeah, this is what I need. And I feel like a lot of the trapezius and the rhomboid, that was pacifying him because he felt good with that. And again, that built that trust to then be able to work on these other muscles and then be able to get him back in. And he was able to play. He was able to come back during the season. He was able to play. He was able to perform. He could do everything that he needed to do. And it was just a great way of, let's talk with all of the people involved. Let's look at the musculature. Let's look at what's going to be affected. Let's look at his limitations. And how can we really work around everything to get to be successful?
I'm glad you kind of wrapped it up like that, because what I'd like you to do now is connect what you've just described about your process of working with this person who A, has a complicated situation, and B, has some really ambitious goals for where they want to be, at the end of their therapy. And I'd like you to relate it back to your book so that we can find the through line there.
Yeah. So the first part of the book really does a nice job of setting up reminders of anatomy and physiology of what massage is. I always use the word purported to do, right? Because we have theories.
Right.
In some cases we have theories. In some cases we've got the research to support it. But we also have to go back to the basis. We have to go back to the physiology of the body. And we have to make sure that what we understand about physiology matches the goals of the session. Right. And so my goal with him was never relaxation. I didn't care. I always care about blood flow, but I didn't care about blood flow. I wasn't working on him initially with swelling where I cared about his manual lymphatic drainage. Right. So that wasn't what we were looking at.
That would be a different set of goals, completely legitimate goals, but not your assignment with this person.
No, I cared about the fascia, the fascial alignment. I cared about the muscle, the types of muscles. So remembering our postural versus our phasic muscles and what their role is in the job in which he's doing, within the sport. So again, knowing and understanding the sport and are the muscles being affected and what are the goals with what we're doing with that musculature. Understanding that it is a structural problem and there are some functional components to it. And I would put subscapularis being a functional component, but pectoralis major, where the surgery was, now that's a structural change. Scapular positioning, now that's going to be a structural change. So we have to consider all of that. We have to consider the types of massage. It was myofascial release. That's a lot of what I really go through in this book. Because everybody learns the effleurage and the petrissage, and those are great techniques and I love them. They are not what my goal was here. I was not trying to engage in relaxation. And even if I did use a petrissage, it would be a quicker motion. I didn't have him for an hour or 90 minutes on my table like I would if he was a traditional massage client. I had him for maybe 15, 20 minutes at a time because we were fitting this in, maybe 15, 20 minutes. We were fitting this in with everything else that he was trying to do. And it was 1, maybe 2 days a week is that I was seeing him. So I wasn't even working on him every day. And I don't think that we should. We should not get in the habit of working on somebody every day. I think massage and any type of manual therapy becomes part of the bigger picture, the strength and conditioning, the the rehabilitation exercises, the other therapeutic modalities. So that was kind of where we were with kind of using the front half of the book. And then also looking at what are the basic massage techniques that I was using, things like a pin and stretch, things like myofascial glides, maybe like a lift and shift of the musculature that we would do. So those are kind of the basics of what I'm looking at, the glides and the lift and shift and the pin and stretch with him. So now I'm thinking about the techniques, and I'm also thinking about the muscles. Pectoralis major is a great muscle to pick up and lift and shift.
Very easily accessible. This would have been much harder if it had been something deeper.
Right. And subscapularis, that's all. That's just resting my fingers.
Or even, serratus or something.
Serratus anterior, yeah. Pectoralis minor, that's just kind of, gentle finger glides, very gentle finger glides.
Doesn't feel gentle when my massage therapist does it.
Yeah, as I always remind people, pressure is an illusion. Pressure is an illusion.
Actually, so the second half of your book is really, it's about function, right?
It's about the anatomy. So here's the muscle. Okay. Here's what the muscle does.
Right.
Here are the techniques we can use for that muscle based on what it does.
Yeah.
And then the other key component is, okay, you don't necessarily have to know about the sport. I know football, that's great, but ask the questions. Ask them what they have to do. Ask if you can get a hold of the physician and get a hold of the notes. Ask them, what are the limitations? What was
with your client's permission? I mean, you're working in a kind of team where that's implied, right? Yes. But that's not the case for most massage therapists. So I'm a big fan of consulting with other members of the healthcare team, but that has to be done with the explicit permission of the client.
Or there's ways to research kind of generally. Mm-hmm. What type of surgery would we see? And that's where our research literacy skills come in, right? Like, what is the current research and the current trends in surgery for a pectoralis major? And those are questions that we can get answered, even if we cannot get the specifics with permission, if we can't talk to the physician. Yeah, we
can dig up a lot of that stuff ourselves. It is true. I mean, it's really nice when you're on a team and you can work with people, but just laying out some boundaries about that, because you talk about people behind their back without letting them know that you're going to do it.
Yes, exactly.
Well, I mean, if I were in practice, and particularly working with athletes, this book would be right up my street, because it's really about balancing structure and function and analyzing, point A to point B and how we're going to get to point B, which is being able to block and also reach. And that sounds amazing. So, where would someone want to look for this book?
So the book is being published by Human Kinetics.
I love that company. They've done some wonderful work.
They really have been a joy to work with. So it will be available through them, but it will also be available kind of any of your other online options. So Barnes & Noble and Amazon. So it will be released through those. And for those who are looking, I know that they're trying to build some continuing education opportunities as well. So if you want to read just for the sake of reading, that's great. If you want it for a reference on your bookshelf for your clients to be able to use it for them, that's great. Or if you want to use it to be able to fulfill those CE requirements,
like a home study course kind of thing.
Some home study courses, I think that would be a great option as well.
Portia, this has been fascinating, and I really appreciate your time. I'm excited about your book. And for massage therapists who specialize in working with athletes, I think this is going to be really, really important. So I want to thank you, and I will be sure to have links to information about you and information about the book in the show notes for today's episode.
Thank you so much for having me, Ruth. It is always a pleasure when we get to chat.
Precision Neuromuscular Therapy has been teaching high-quality seminars for over 20 years across the country. Founded by Doug Nelson, PNMT uses problem-solving skills and precise treatment options to get powerful results for your clients. PNMT seminars focus on honing your assessment and palpation skills to precisely target the source of your client's pain while understanding the why behind the what. Meet us in a hands-on seminar or online in the PNMT portal and let us join you on your learning journey. Learn more at pnmt.org. Elevate your bodywork career with Anatomy Train's Structural Integration Certification, ATSI. Discover how to map the pattern and shape the change through inspiring lectures, hands-on body reading, and practical techniques you can use in your practice right away. Join us for ATSI Maine 2026 to 2027, where Tom Myers will personally kick off this transformative professional training. Learn more at anatomytrains.com/ATSI.